everyone. It is my greatest pleasure today to introduce our speaker, Dr. Nanette Wenger. Dr. Wenger received her undergraduate degree from Hunter College and her medical degree from Harvard Medical School. She continued on to her residency at Mount Sinai Hospital in New York before completing her cardiology fellowship at Emory University School of Medicine. Notably, Dr. Wenger has been practicing medicine for 60 years, during which time she has established herself as an eminent clinician, leader, researcher, and most importantly, pioneer in the field of cardiology. She has authored or co-authored over 1,500 journal articles, book chapters, guidelines, and review papers. She has chaired, committeed, and served on expert advisory panels for the World Health Organization, the National Heart, Lung, and Blood Institute, the Food and Drug Administration, the American Medical Association, the American College of Cardiology, the American Heart Association, serving at the highest level in these organizations. And these are truly just a few that I pulled from looking at her CV. Throughout her career, Dr. Wenger has received numerous prestigious awards valuing her contributions to medicine, consisting of the highest honors Professional Organizations Award, endowed lectures, and Lifetime Achievement Awards. In addition, she was cited as one of Time Magazine's Women of the Year in 1976, and in 2003, she was included in the National Library of Medicine exhibition entitled Changing the Face of Medicine, A History of American Women Physicians. Although the accomplishments of Dr. Wenger's career are impossible to capture in a brief introduction, I would like to recognize three particular areas of her contributions to science and medicine. She was one of the first physicians to demonstrate the safety and efficacy of early physical activity and rehabilitation for patients with acute myocardial infarction, thereby serving as a pioneer in the cardiac rehab movement. Today, cardiac rehab is prescribed to every patient after a cardiac event. She was also the first to fully describe the unique facets of coronary heart disease in women, defining the sex differences in symptoms, and drawing attention to the fact that heart disease in women was inadequately recognized and treated. She has also led the charge among cardiologists to improve treatment of heart disease in the elderly. And finally, when we reference the term pioneer, it is impossible for us today to really recognize the extraordinary accomplishments of Dr. Wenger as a female cardiologist who first began to practice in 1959. As my colleague at Hartford Hospital, Dr. Paul Thompson, describes her, she was a woman in cardiology in a time when no one, and I mean no one, was a woman in cardiology. That Dr. Wenger has had such an extraordinary career speaks to her capacity to inspire, to lead, to educate, and to work tirelessly to improve the lives of countless patients. So please, join me in welcoming her to University of Connecticut.
Beth, thank you, and happy Valentine's Day to everyone. And this seems a very appropriate time to talk about understanding the journey, the past, present, and future of cardiovascular disease in women. These are my disclosures, and I think you will understand in a few minutes why I have chosen as the theme for this presentation the statement from Victor Hugo back in 1877. He said, "There is nothing as powerful as an idea whose time has come." Obviously, the context was very different, but I think you will see what my context is. And it comes from this cartoon. And you have to remember, this is 1991 cartoon. And we see the physician seated across from a woman patient saying, "We have studies of fruit flies, mice, hamsters, frogs, monkeys, and men with this condition. But medical research using women as subjects just never occurred to anybody." Well, fortunately it did. And I will show you what the results were. These are the trends in cardiovascular mortality in the United States, and you can see the men in the solid line, the women dotted, and through the end of the 1990s, the decline in cardiovascular mortality was solely in populations of men. And then examine the change. Beginning in the year 2000, there was an abrupt decline in cardiovascular mortality in women in the red, much more prominent indeed than the decline in men in the blue. And then about 2013, for the first time since the data were recorded, fewer women than men died every year from cardiovascular disease. And as I've said in other forums, we are delighted to be in second place, and we hope to stay there. But I want to show you what is the worry, what should be all of our worries. And that is the uptick in cardiovascular mortality in men and the leveling off in women. And this has occurred solely among the younger subsets, those men and women aged 35 to 50 or 54. So we certainly have a great deal to do, but that is an area of worry for all of us. Let me show you where some of this started. And this is 1964, the Oregon Heart Association. It was the first women's conference on heart disease. And what was the title? Hearts and Husbands. The women were taught how to take care of their husband's heart. And then when the American Heart Association introduced the Heart Association's diet to the American public, it was called The Way to a Man's Heart. Then look at the year, 1970s, and Dr. Harriet Dustin and I did a television series on heart disease in women. But look at the time, 11 p.m. We were the late night news rather than middle of the day as we do today. And what I want to do is to carry you through some of the steps on the journey to show you what happened that occasioned this change. Far back in 1986, we finally convinced the National Heart, Lung, and Blood Institute to convene a workshop on coronary heart disease in women. And you know, usually a workshop to a conference is 6 months or a year. This one was from 1986 to 1992. But finally it happened. And at that conference, which it was my privilege to co-chair, we identified flawed assumptions. First, that women did not experience heart disease until they were elderly and not as seriously as men. And we showed that those data were wrong. We highlighted the new information that was appropriate for clinical care and identified the research agenda, the knowledge gaps that impeded optimal cardiovascular care for women. But I think it was because the conference proceedings were published in the New England Journal of Medicine that women and heart disease became a topic for discussion and, importantly, for research. Fast forward to 2001, the report from the Institute of Medicine by exploring the biological contributions to human health. Does sex matter? And essentially what the Institute of Medicine said is that there's a need for the evaluation of sex-based differences in human disease and in medical research, and translation of these differences into clinical practice. Then we began to get randomized trials of important issues. And the first was menopausal hormone therapy. Now, one of the reasons that heart disease was not thought to be a problem for women is that women were thought premenopausally to be protected from heart disease by their intrinsic hormones. And then what was told to women across the United States is after menopause, menopausal hormone therapy will cure everything from wrinkles to depression. And heart disease was somewhere in between. Observational data, not the first randomized trial, and then we began to get randomized trial data. The first was hers, the Heart and Estrogen Progestin Replacement Study, and the next, the very large Women's Health Initiative of the National Heart, Lung, and Blood Institute. And what was found was that menopausal hormone therapy did not prevent incident or recurrent cardiovascular disease, and indeed there were some downsides, cancer risk, venous thromboembolism, etc. And the conclusion was that menopausal hormone therapy was not indicated for the primary or secondary prevention of cardiovascular disease. And what that did was to focus attention on the established cardiovascular preventive therapies for women. Then again, a very important report from the AHRQ about what was the status. Now, this was 2003, not that long ago, of the diagnosis and treatment of coronary disease in women. Systematic review, and the conclusions were that most of the contemporary recommendations for the prevention, diagnostic testing, medical and surgical treatments of coronary disease in women were extrapolated from studies conducted predominantly in middle-aged men, and as a matter of fact, in middle-aged white men. And they identified fundamental knowledge gaps regarding biology, clinical manifestations, and optimal management strategies. And this is really what spurred some of the data that were translated into improved outcomes. Then advocacy, which is a very important component of this. 2004, 15 years ago, the National Heart, Lung, and Blood Institute's Heart Truth campaign, and basically heart disease doesn't care what you wear. That was the message behind that. And the one that we all know in the same year, the American Heart Association's Go Red for Women, and that established the red dress as a symbol of heart disease in women. And then the same thing, Women Heart, the National Coalition for Women with Heart Disease. But these were the educational and advocacy arms that were equally important in reaching women, as were the data from the scientific studies. Then we began to get specific studies. First is the Women's Health Study. Again, a study conducted solely in women because the previous study, the Physician's Health Study, was in men. But what Women's Health Study found is that aspirin for women prevented stroke, but not incident myocardial infarction. In contrast, in the Physician's Health Study, aspirin prevented myocardial infarction, but not stroke in men. So very different outcomes, again, highlighting the importance of examining sex and gender differences. Then important data from quality improvement registries. This was the CRUSADE registry, and these were women with non-ST elevation myocardial infarction, not the major severe infarct, but the smaller ones. And what they found was that the acute coronary syndrome prognosis was worse in women. Women had more hospital death, myocardial infarction, heart failure, stroke, and transfusion. And you will see that transfusion recurring. Women, for reasons not yet established, have an increased bleeding risk with virtually all syndromes. And CRUSADE found that women were less likely to receive coronary interventions and guideline-based medical therapy, despite the fact that they were at higher risk. And the question then was rather obvious. Was their worse prognosis related to a difference in baseline risk or suboptimal admission and discharge therapies? And I raised the question, was this biology, was this bias, or was this both? And I expect it was both. Then something that is a landmark difference, a sea change in understanding anatomy and pathophysiology. And that's the National Heart, Lung, and Blood Institute's Women's Ischemia Syndrome Evaluation, or WISE. And before WISE, what happened is that women who had an abnormal imaging study, an abnormal non-invasive test, stress test, and then went to the cardiac catheterization laboratory and didn't have obstructive disease in their epicardial coronary arteries, everyone would shrug their shoulders and say, false positive non-invasive test. And I think we have removed that phrase from our vocabulary. That was not a false positive test. There was myocardial ischemia. It was simply not related to obstructive disease of the epicardial coronary arteries. And what WISE showed us is that in women who'd had an acute coronary syndrome or otherwise, many did not have obstructive disease of their epicardial coronary arteries, but that the fact that they had myocardial ischemia was associated here with adverse clinical outcomes in the absence of obstructive disease. And we now realize that many of these women had microvascular disease. Many of these women had non-obstructive disease. They all resulted in myocardial ischemia, but it is that ischemia that kills. And now we realize that we women are more complex. Men also have non-obstructive disease and microvascular, but less frequently than women. So when a woman has myocardial ischemia, it may be microvascular, it may be non-obstructive, or it may be obstructive coronary disease. And now, as I will show you, we're beginning to get test modalities to tease these out because their management strategies are likely different. Then again, some more research studies, important trials. This was the women's antioxidant cardiovascular study and the antioxidant and folic acid study. And these now, remember, in the early 2000s, were standard therapies for women and for men to prevent cardiovascular disease. And what the studies found was that vitamin E, vitamin C, and beta-carotene did not prevent incident or recurrent cardiovascular disease in women, nor did folic acid and the B vitamins. Again, officially it removed ineffective therapies from the recommended preventive regimens and focused attention. But I will tell you, it was a challenge for me to get my women patients to renounce their vitamin C and vitamin E, which they dearly loved, and were taking instead of some of the effective preventive therapies. But we did have the trial data, and now those are not part of the standard regimens, either for women or for men. Then again, more information from database. And cardiologists have been very invested in registries and databases. And this is the Get With the Guidelines database. And what Dr. Genet had found is that women had an increased mortality with ST elevation myocardial infarction, the so-called STEMI. And it was double that for men. But it was predominantly mortality in the initial 24 hours. So they looked back for the granularity of those initial 24 hours. And women received less early aspirin, less beta blockers, less reperfusion, and less timely reperfusion. These are life-saving therapies. Now, it's not that physicians were saying, I'm not going to treat my women patients as well as the men. This was unrecognized myocardial infarction, often young or middle-aged women coming in with chest pain and not undergoing the rapid initial emergency room evaluation. This gave us opportunities to decrease the gender disparities in care and to improve clinical outcomes. Now back to the Institute of Medicine, and a decade later, what the IOM did was to report on women's health research. What was the progress, what were the pitfalls, and what were the promise? And the conclusion of the Institute of Medicine is medical research historically neglected the health needs of women. And this was what I have termed bikini medicine, that for women, they focused on the areas covered by the bikini bathing suit, the breasts and the reproductive system. And the rest of women's health was left largely unexplored. And the IOM defined women's health as sex differences, the biologic factors, and gender differences, those that are affected by broader social, environmental, and community factors. And they acknowledged that we began to improve cardiovascular mortality, but recommended more research to quality of life issues, functionality, mobility, and wellness, and more to the Institute of Medicine. Women are not a homogeneous group, and that there are major disparities in the disease burden among subgroups of women, particularly those women who are socially disadvantaged because of race, ethnicity, income, or education, and recommended targeted research on women with the highest risks and burdens of disease. And then they went to the journals and the journal editors. And with a journal editor here in the audience, I think we will realize, they said the lack of analysis and reporting of sex-stratified analyses limit the ability to identify potentially important sex and gender differences, including differences in care. And they challenged the journal editors to require clinical trial outcomes to be presented separately for women and for men. And then translation of women's health research findings into clinical practice and public health policies, and effective communication of research-based health messages to women, to public, to providers, and to policymakers, as we are doing today. Then we began to get some prevention guidelines. And in 2011, the Women's Prevention Guidelines were updated and highlighted some areas particularly new and unique to women. And that was the issue of pregnancy complications. And as most of you know, often the obstetrical record is separate from the entire medical record, and these data are not transferred. And I tell my women patients, be sure your primary care provider has your obstetrical records if you have to hand carry them there. And what was found is that pregnancy complications, particularly preeclampsia, gestational diabetes, pregnancy-induced hypertension, are all indicators of early cardiovascular risk. So that if we are going to do risk factor assessment for women, a detailed history of pregnancy complications is a routine component of that assessment. We also highlighted for the first time that systemic autoimmune collagen vascular disease, not unique to women, but predominant in women, increases cardiovascular risk, and that women with these disorders should be screened for the cardiovascular risk factors with appropriate intervention. Now, what do we see as contemporary help for Sisyphus? Because over the first years, we felt as if that boulder were going up the mountain and then coming back down again. And what I want to do is to review the gender-based medicine in cardiology, the state of the science, the scientific statements just in the past decade. And I've tried to pull them together as best I could. This was the prevention update that I just mentioned, and what it said was to evaluate cardiovascular risk, you evaluate family history, history of pregnancy complications, but also define that depression screening should be done in women with cardiovascular disease because depression is a risk for worse outcomes. And also stroke prevention for women with an arrhythmia, atrial fibrillation, because atrial fibrillation increases the stroke risk 4 to 5-fold, and under treatment with anticoagulants doubles the risk of a recurrent stroke. Next is a scientific statement on women and peripheral artery disease. And the highlights of that is that really surprisingly very limited epidemiologic data for women. But the total burden of peripheral arterial disease seems higher for women, and women may have higher event rates. But we emphasize there that women, just like men, don't have classical claudication symptoms. So you really have to look and test. But importantly, with the peripheral artery disease, that women, compared with men, but especially Black women, more likely to experience graft failure if they're revascularized and limb loss. The amputation rate is highest among Black women, and obviously a need for more gender-specific data. Then a guideline for the prevention of stroke in women. And as you can see, we are really covering the waterfront. And what that guideline showed us is that there's sex-specific stroke risk factors for women: pregnancy, preeclampsia, gestational diabetes, oral contraceptive use, menopausal hormone therapy, and changes in hormonal status. but there are risk factors that have stronger or greater prevalence in women. And those include migraine with an aura, atrial fibrillation, diabetes, hypertension, depression, etc. So here it outlines the profile of the woman at increased risk for stroke. Then we're talking about how do you test? What is the role of non-invasive testing for women who are suspected to have ischemic heart disease? Because we've just discussed that ischemia kills. And here, very low risk women, the woman with chest pain that we don't think has coronary disease, are probably not candidates for more intensive and recurrent diagnostic testing. But the simple exercise ECG, the treadmill exercise test, is the initial diagnostic strategy for low and intermediate risk women who have the ability to exercise and an interpretable resting electrocardiogram. And then if you have a symptomatic woman who has functional disability, she can't exercise, an indeterminate or uninterpretable or abnormal resting ECG, then you do the advanced testing with echocardiography, myocardial perfusion imaging, magnetic resonating, and now more and more we're seeing recommendations for coronary CTA. Then sex differences in the cardiovascular consequences of diabetes. Again, diabetes, we're beginning to realize, essentially eliminates the gender difference that women have over men in terms of the incidence of coronary disease. The diabetic woman looks more like a man. And what was identified is that lifestyle interventions, and remember, this is not medication, lifestyle interventions may improve cardiovascular mortality more in pre-diabetic women than in pre-diabetic men. Very important lifestyle. And that abdominal adiposity and insulin resistance predict cardiovascular events in women versus men. But women with diabetes may need more frequency and intensity of physical activity than men to decrease their cardiovascular events, and our exercise physiology people may be able to figure out why. But as I suggest that the gender advantage of less cardiovascular events in women is lost in the context of type 2 diabetes. So certainly a very different landscape for women. Then a lot of this is imaging because the testing is advancing so rapidly. And what about non-invasive imaging to evaluate women now not with suspected ischemia, but with stable ischemic heart disease? And basically, symptomatic women have worse outcomes than men. And one of the questions that's being raised is now we're having computed tomography, we're having coronary CTA with vasodilator perfusion imaging, and these can identify not only the epicardial obstructive disease, but the microvascular. And what we need is trials focusing on non-invasive approaches and strategies. We still don't have therapy for non-obstructive disease or microvascular disease. Nothing has been shown to improve outcomes. And what about acute myocardial infarction in women? I showed you the data from decades ago. Marked reductions, as I've shown you, in cardiovascular mortality, and it is probably a combination of increased awareness and the focus on women and their cardiovascular risk, and the application of guideline-based therapies. But there is still an excess mortality in women with acute myocardial infarction because they are undertreated with guideline-based recommendations, and because of that, they have greater readmission after myocardial infarction, reinfarction, and the woman who has had a heart attack is more likely to die in the first year after that heart attack. Again, public health educational messages to target racial and ethnic minority women because these are the women who have the worst outcomes and who need the most intensive interventions. Then again, myocardial perfusion imaging, because these are expensive, intensive and radiation-producing tests. Both SPECT and PET MPI specific tests can risk stratify women with stable ischemic heart disease, and the addition of coronary flow reserve to PET improves the risk detection for women. Again, now we're beginning to say we have a modality that can detect not only obstructive, but non-obstructive disease and coronary microvascular disease. And if we can apply and have greater availability of this multiparametric imaging, we can visualize the anatomic plaque and possibly uniquely identify the at-risk women. The two things that are needed are, first, radiation dose reduction strategies, a very important target. And second, we need randomized comparative effectiveness trial data to say which of these tests are the best for women. Now, we're straying a bit away, but importantly, cardiovascular disease and breast cancer, where these entities intersect. Because the tragedy that I see is the woman who has breast cancer cured with chemotherapy. And I have to say to this woman, your cancer is cured, but now as a consequence of chemotherapy, you have heart failure. Not an ideal trade-off. The fact that there are overlapping risk factors for cardiovascular disease and breast cancer, such as obesity and smoking, and that many of the current breast cancer treatments may cause both left ventricular dysfunction, heart failure, and accelerated cardiovascular disease. What we've seen is just a huge increase in population of breast cancer survivors. The survivorship from breast cancer is in the 90%, and the freedom from recurrence in the 97%. But they're at risk of long-term complications from their cancer therapies that have made them cancer-free. What we now have to have is surveillance, prevention, and secondary management of cardiotoxicity during breast cancer treatment. And we now have a few trials that show us that some medications may ameliorate some of this treatment toxicity. And now this is a statement from the American Heart Association and the American College of OBGYNs. Because remember, for many apparently healthy women, their OBGYN physician is their primary care physician. And therefore, we are now saying to the OBGYN colleagues, you have this responsibility. And the OBGYNs function in a preventive mode. They do pap smears, they do breast cancer, mammography. Now we're saying we need to get you into the cardiovascular sphere. And the important feature that we identified in this statement that just came out last year is 90% of women in this country have at least one risk factor for cardiovascular disease, and women are less likely to receive guideline-recommended therapies. The important feature is that healthy lifestyles and behaviors should be discussed at every visit, and screening for cardiovascular disease and cardiovascular risk should be enhanced, and then shared information to assess risk, to initiate interventions, and importantly, to facilitate lifestyle changes. Here we have a major emphasis on lifestyle prevention rather than going immediately to the medication sphere. Now, let me go back to the clinical trials. It's not a huge amount of information just in one decade, but we have a challenge about women in clinical trials. As I've suggested to you, women were underrepresented in mixed gender NIH trials, and even when they were represented, they were disadvantaged by the absence of gender-specific analysis. Even though women in clinical trials have increased over time, only 20% of the acute coronary syndrome trials were women. Cochrane reviews, which really are some of the best reviews we have done, and these are 258 cardiovascular clinical trials. Only a third of them examined the outcomes by sex, and among those third, with sex-based analysis, 20%, 1 in 5, reported significant differences in outcomes between women and men. Obviously, we need to go back to some of those trials, and prospectively, we have to handle it very differently. And one part that is very important to me is that the exclusion of elderly patients from clinical trials doubly disadvantages women because women have a predominance of coronary events at older age. Now, this is, again, life-changing. And this is HR 2101, the Research for All Act of 2015. And it shows us that we really can have a very progressive and functional Congress. This was introduced in April of 2015, and it included a mandate by the Government Accountability Office to update reports on women and minority inclusion in medical research at the NIH and at the FDA. These are the two government agencies. And the NIH had to ensure both male and female cells, tissues, or animals were included in basic research. It was rather amazing, but talking to basic researchers, most of them were not sure of the provenance of their tissues or their cells. Did they come from male animals or female animals? Were we using cells and tissues for male animals to study female disease? New requirement. And then the results disaggregated by sex and sex differences, and then update guidelines on women and minorities in clinical research. And those of you who have put in applications very recently to the NIH will realize that you must identify how you are going to include women and minorities in the clinical trials, and you have to have not, we will include women and minorities. That no longer suffices. It will not pass the triage. You really have to have a plan for what you do and how you manage if your early recruitment doesn't meet these targets. And then the FDA, because the FDA really regulates industry. FDA has to ensure that clinical drug trials for expedited drug approval are sufficient to determine safety and effectiveness for both women and men, and that these are supported by the results of clinical trials that separately examine outcomes for women and men. As you know, industry, if they have a new drug or a new device, goes to the FDA and says, this is the planned trial. And if we do this trial and if we get results, is it likely that we're going to get approval? And this is the time that the FDA will tell them, this is what you have to have. It's going to be, I think, 5 to 10 years before we begin to see the results of these. But this is landmark legislation, and I think it is the first of many steps in the right direction. But my vision is to expand the landscape of women's cardiovascular health research. And what I would hope to see in the next decade is research that addresses beliefs and behaviors, the community, local, national, and global, economic issues, environmental issues, ethical issues, legislative and political issues, public policy, societal, and sociocultural issues. And that's the reason I think it's important to explore gender differences in cardiovascular disease. And I thank you for your attention.